has begun.
Good morning, everyone. Welcome to our program today. I just wanted to say hello. My name is Jordan Baker Friend, and I'm with the University of Nevada School of Medicine. And I'm here to just welcome you to our webinar and introduce our wonderful speaker, Dr. Howard Chin. Dr. Chin is the Medical Director of Health and Wellness at Renown Health in Reno. He is board certified in family medicine and a fellow of the American Academy of Medical Acupuncture and has a special interest in preventative and integrative medicine. I just wanted to show you this is our welcome page here and our title slide, and then direct you to these are our learning objectives and our disclosure policy should you have any questions. And we are so honored to have him with us today. And without any further ado, we're going to jump right into this. If any of you are having any technical difficulties, just let me know. You can email me or call me, and I'll be able to help you out. So here we go.
Thanks, Jordan. I really appreciate the introduction. Well, everybody, thanks for joining in. I realize it's your lunch hour, so we'll try to keep it short and informative. But we have quite a few participants today, so that's quite nice. So anyway, today, as you can see by the slide, we're talking about the non-pharmacological and non-surgical management of acute and chronic pain. I think there's a lot to talk about in this topic, which is, I guess, why we have an hour, but there's a few very important things I think we'll probably need to talk about. So here are some of the learning objectives that we're talking about, the kind of the multifactorial etiology of pain, which is probably the most important thing to get across today. And I'd also like to give you quite a bit of information on several different methods for treating pain. It's not necessarily just integrative methods, but actually all kinds of different methods, anywhere from things that we're quite used to, including physical therapy, all the way out to, at the end, we'll actually even talk a little bit about cannabis. So here's the lecture outline, just in general. So we'll talk about the definition of pain in general, and after that we'll go into kind of why chronic pain is so difficult to treat and why the treatments of pain with pharmaceutical medications is in some ways especially problematic. And we'll be talking specifically about side effects at that point and why the integrative method of pain management is essential. Now, when I say integrative, I don't necessarily mean that we have to use alternative medicine or complementary medicine, just more that using several different methodologies or treatments for pain rather than just giving them narcotics or surgical options in this case. So we'll also talk a little bit about the conditions that non-pharmaceuticals have been shown to treat successfully and maybe what are the examples of some of the effective non-pharmaceutical treatments. Putting this lecture together, I thought, what is the information that's out there? So a lot of my research has actually been into the Cochrane reviews. Many of you have heard of these, which are basically large reviews of all the literature that's out there, specifically focusing on randomized controlled trials, but also looking at some of the other kind of well-done case control studies, things like that. And then finally, the biggest question and probably the most important question for all of us in practice is how do we actually put this integrative treatment of chronic pain into practice? What do we actually do? Because it's very easy and not time-consuming in some ways to write out a medication, but are there other options that we have for helping patients with their pain that are maybe just as easy? By the way, I'm able to see the public chat, and I can certainly see all you guys saying hi. That's wonderful. And if you have any questions, please feel free to type into the public chat, and as we go along, I'll try to answer them as well. So, okay, let's go on to the next slide here. So first, let's start with the statistics of pain, because it's important to know how much pain is out there. And you can see it's the #1 indication for medical office visits across the United States. It affects probably greater than 1 in 5 people, with the number over the next few decades expected to increase to 1 in 3 people in the entire United States. And you can probably see the same thing in your office. You probably deal with pain day in and day out, unfortunately, for many of us. And so statistically, chronic pain affects 100 million people in the U.S., which is about a third to about a quarter of the entire population. That's quite a bit of pain. And what's even worse is that the societal costs of pain are upwards of 560 billion. The number that I looked at actually was somewhere between 560 to 640 billion dollars per year in missed workdays and medical expenses. So it's a large expense. And of course, it's not just pain that's causing all these expenses, but it's, as we know, the kind of driving factor for people to see medical care. And so it's a big problem. And unfortunately for us, with a larger population ever growing, the pain problem is probably not going to go away. So what is pain? Here's a definition from the International Association for the Study of Pain. They're kind of the people who put out the, I guess, most comprehensive way of looking at it. So I think this is a very important thing to take a look at. It's an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage or described in terms of such damage. I want to stay on this slide for a few seconds only because let's take a look at it. Sensory and emotional experience. And you know this is quite true in your patients. It's never just, oh doc, I have pain. It's, oh, I have pain and I have a lot of anxiety about it, or I'm about to have pain and I'm feeling quite anxious about it, or I've had pain for years and now I have depression in addition to the pain because dealing with the pain has affected my mental health. And so, unfortunately, and I'm actually quite happy that they've put it into this definition from the IASP, pain is a sensory and emotional experience. And what's more important is that it doesn't actually need actual tissue damage. We used to think, okay, well, if we can't find any evidence of tissue damage, well, there's no pain. Why would there be? But we find that there's many things that we actually can't see, and whether it's micro tissue damage or it's potential tissue damage, those are still pain. So on the bottom of the slide, we talk a little bit about acute versus chronic pain, and truthfully, the difficulty with differentiating between acute and chronic pain is that the time frame is strange. Some clinicians would say, and some large reviews of pain would say that chronic pain starts within 3 months, or is it 6 months, or is it after you've had pain for a year? But I think maybe the best definition of chronic pain is the pain, although this isn't a good definition for research, is it's actually pain that persists longer than you expect it to. So we can even say that the pain of a laceration, if it doesn't go away after the skin is healed, you can start to call that chronic pain, even though it's maybe a week or two, and the laceration is healed, but you still have pain. So again, another definition that I like, in addition to what's on the slide, is a pain that's in some ways overstayed its welcome, or pain that has not diminished or decreased as expected to. As you can see, that's probably not so good for a research definition, however. It makes it a little bit difficult to understand. Here's a slide on the types of physical pain. There's nociceptive pain, and the next slide that we'll talk about is neurological type pain. And so we won't spend a whole lot of time on this because the slide itself spends a little bit more time speaking about kind of the medical treatment or the medication treatment. But in general, there's some divisions between nociceptive pain, which is generally the pain that most people think about. It's kind of the sharp pain, the acute pain. And so there's central locations and peripheral locations of pain, and there's superficial as well as deep pains. And I think the important part about this slide is that in the deep section, you can get deep somatic pain and you can get deep visceral pain, which means that even though we're not necessarily used to feeling it, the pain also can exist in the organs. One of the most common examples, of course, is if your heart is feeling deep visceral pain, then you'll get pain down your arm. Your heart, it'll be very difficult to localize this pain, and the pain may go somewhere else. But and the same thing, of course, happens with deep abdominal pain in the organs. You may have very difficulty localizing the pain, but it's important to know that not only do the things that we normally associate with pain, such as ligaments or tendons, when you rupture a tendon or break a bone, disrupt muscles or blood vessels, that's one type of pain, but it's also important to realize that visceral pain and the pain of the organs is also a factor. Overall, pharmaceutical medications do pretty well in terms of treating nociceptive pain. Let's take a look at something they don't treat very well. It's neuropathic pain. So neuropathic pain, we've all experienced, or if not experienced it yourself, you certainly have patients with neuropathic pain. it's a peripheral or central pain, but in general it's a burning or a tingling or electrical feeling, or maybe a numbness, or the numbness that burns or the numbness that hurts. And what I find interesting about this slide is that we can generalize that to other things that are in some ways confounding or difficult for us to treat. So is fibromyalgia actually a type of neuropathic pain, or irritable bowel, or TMJ? Very likely. And so many of these pains, many of these neuropathic type of pains, respond best to centrally acting neuroactive compounds, such as antidepressants and anticonvulsants. And you probably already have a good idea that neuropathic pain, and the common example is diabetic peripheral neuropathy, is very, very difficult to treat straight with opioids or NSAIDs. And so it takes something else, probably, or most likely because it's a different type of pain. All right, so why should we treat pain? It's a big one. The problem with pain is that the burden of dealing with unremitting pain can be devastating to the patient's psychological well-being. It affects almost everything when you have a chronic type of pain, even acute pain. It affects your relationships, it affects your job, it affects your ability to socialize, it affects how you feel about yourself, your self-esteem, and even your mood and your willingness to do things in life, to get on with your activities of daily living. So we can say that the importance of treating pain is that pain affects so many different things in our life that if we don't treat the pain, we can't actually expect our patients to be able to function well in the rest of their lives. Again, job or relationships with their significant other or children, things like that. So pain affects everything, and it's not just, unfortunately, the thing that's in pain. But because the pain is multifactorial, we have some opportunities. You can already see that because there's physical and emotional attributes, the adequate treatment of pain is very likely to require the treatment of all these different things. Unfortunately for us, it's not necessarily as simple as getting rid of the pain, because even if the pain is gone, you still have to deal with the emotional and the psychological consequences of things, of the pain. And so thus, probably the best treatment is a comprehensive integrative approach which combines multiple therapies. And again, please don't be too worried. We're not just talking about things like acupuncture or yoga. We're talking about even many of the things that we already know. And some of the best evidence for the efficacy of an integrative pain approach comes from a 2008 Cochrane review on biopsychosocial rehab for subacute low back pain. And when we say biopsychosocial, the criteria for kind of getting into these studies was, of course, being seen by a physician, but also having some type of psychological intervention and a physical intervention as well, so whether it was physical therapy or massage or exercise. And so it found some pretty good results for this integrative approach for subacute low back pain. And I feel as if we can generalize from that to not only acute low back pain, but of course also chronic low back pain. As another reminder, as I go through these slides, please feel free to ask any questions on the public chat. All right, so let's talk about some of the confounders and some of the ways that we're unfortunately failing in the treatment of chronic pain. Chronic pain, like many other chronic illnesses, actually requires management rather than cure. Although we've spent years thinking that maybe if we just give the right medication, maybe we can lead to a cure. Maybe if we just get our Norco prescription exactly correct and our patients would take the medication on time, Q4 hours or Q6 hours, maybe that would cure their pain. But the truth is that it's a chronic illness, and you can't actually cure this particular chronic illness, like many chronic illnesses. So the best practice models for chronic pain management require a multidisciplinary approach similar to that of all the other chronic illnesses: depression, dementia, diabetes, eating disorders. Chronic pain is a chronic illness, not a curable illness, unfortunately, or very unlikely to be cured. The other important factor to note is that pain is not a static phenomenon. And so when we talk to our patients saying, you know, Joe, you should take medication, you should take your narcotic every 4 hours, or if you're taking a long-acting narcotic, you should take it every 12 hours, the patient themselves is saying inside their mind, wait a second, what if I don't have pain at that particular time? Or what if I have more pain than expected? Can I take more or can I take less? And so we try to get around it by giving a chronic medication like a long-acting and in addition a breakthrough medication. But it's a difficult factor because what happens if the patient doesn't need the chronic medication, the long-acting medication at that time? And so in some ways, we treat pain in a fashion that's somewhat easier to us, not knowing that or not recognizing explicitly that the pain is actually a dynamic phenomenon which comes and goes. It may be better, it may be worse. And you know your patients tell you this all the time in that, doc, some days I have good days and other days I have bad days. Why do they keep taking the same chronic medications or the same long-acting medications? Anyway, so here's another problem with pharmaceuticals in the treatment of pain. We would like to think that our methods treat pain very well, but the trouble is that we still have pain. Every one of my patients, and very likely every one of your patients, says to you, even when I have and I'm taking the right medication, I don't feel like I used to in terms of not having any pain. I still have some pain, although I can ignore it better, or I can move around better, or I can go about my activities of daily living better, despite the fact that I still have pain. And that's with maximal treatment. And so does that mean that we're missing something, some opportunity in terms of how we can treat pain better? I think so, but that's the later part of this talk. So here are some of the concerns with opioids. You already know all of these: constipation, sedation, addiction, misuse, abuse. And surprisingly, there's not actually good data on the long-term use and management of chronic pain. Let's take a little bit more about the opioids. So here we go. 17,000 overdose deaths involving opioids in 2011 based on CDC reports. And the next section down, in 2010, 1 in 8 deaths in persons aged 25 to 34, which is, I would say, a little bit scary, because these are not people who should be dying from opioid use. And even scarier is a 2013 report from SAMHSA that talks about persons in their young ages, whether it's teens or young adults, who are abusing analgesics, and 54% found that these young individuals were getting the medications, getting these narcotic medications, free from a friend or relative. Whether they were given or whether they took them, who knows? But the potential for abuse, and actually the actual abuse, is quite staggering, unfortunately. So, what can we do about it? Here's some non-surgical pain treatment modalities. We'll go through each one of these in a little bit more detail. Over the course of putting the slide together, I've made an effort to take a look at the review studies, the RCTs, things that would give us some good data as opposed to the one-off, the case studies that would say, hey, there's one small bit of evidence. Here we are talking about a lot of different evidence. So let's take a look at these. Here's a slide on which conditions can be treated with non-pharmacologicals. This is actually, I don't love this slide because truthfully we can treat almost everything with non-pharmacological methods. But I think the utility of this slide is to show that there's a lot of the chronic pains, a lot of the most difficult pains, including fibromyalgia or chronic regional pain syndrome, can actually be treated by non-pharmacological treatments. Let me waylay us for a few seconds. I hope you don't mind. We're going to talk a little bit about the lifestyle contributions to pain. There's some groundbreaking work that's come out recently that talks about how our lifestyle actually contributes to pain. In my own clinic, I noticed that many of my patients who have chronic pain are cigarette smokers. And for years I've wondered if there's a link. And it's easy for us to say that, yes, there is a link. But if we take a look at the data, now we find out that it's actually, there's good data that says it aggravates the progression of back pain and arthritis. It's an independent risk factor for lateral epicondylitis. And most importantly, it decreases pain threshold and increases the frequency and severity of the experienced pain, which basically means that cigarettes are a risk factor for chronic pain and being more sensitive to pain. Just another reason for people to quit cigarettes, or for us to emphasize people to quit cigarettes. And of course, I think that this probably follows through for chewing tobacco as well as other methods of nicotine absorption, unfortunately. And here's something else, the second part of the slide. Excess body mass is unequivocally associated with chronic pain, including back pain, osteoarthritis. And body mass and pain threshold are inversely related, which basically means the higher your body mass is, the more susceptible you are to pain as well. And I know that most of you already suspected these two things about smoking cigarettes leading to chronic pain and excess body mass leading to chronic pain, but here's actually some data from Dean and Sunderland. It's and of course the references are at the bottom of these, the back end of the slide set. But here's some really good evidence that actually shows that yes, these things that people are doing to themselves are actually causing them more pain or leading to their likelihood of receiving more pain. So physical inactivity, very similar to what we just talked about in terms of obesity, of course leads to joint degeneration, but we find that there's, of course, the chicken and the egg phenomenon, which individuals with chronic pain are generally less active due to fear, maybe, but of course, if the same holds true in reverse. If they're less active, they're very likely to have chronic pain as well. And we find actually that increasing people's activity level, despite the fact that they have more pain in the beginning because they're not used to their slightly higher activity level, actually eventually decreases their disability level as well as their pain. And then there's sleep. And sleep, 50% of individuals with low back pain have insomnia. Probably the other most common topic that you talk to your patients about is, "Doc, I can't sleep." And we find that insomnia, just like obesity or smoking or physical inactivity, lowers a patient's pain threshold and pain tolerance. The people who sleep better report less pain, amazingly. And regular REM sleep is essential to minimize free radical production, decreases tissue irritation and damage. So lifestyle, wow. Smoking, obesity, physical inactivity, sleep, these all have contributions to chronic pain. Wow. And it sounds like it shouldn't be revolutionary, but Dean and Sutherland, these guys actually, it's the first time that somebody's actually published about this information. This slide talks a little bit about mental health disabilities from chronic pain, which I'm sure that we all already have a pretty good idea. Many of our chronic pain patients are depressed, but we find that interestingly, if we do things to get rid of chronic pain, that also gets rid of depression as well. So if people increase their physical activity levels, it actually improves people's depression as well as their anxiety, as well as their stress. And the more depressed you are, of course, the more you'll feel the pain. So all these different lifestyle contributions, I think, are very, very important. Now we have even better reasons to talk to our patients about lifestyle because it has a large effect on chronic pain. Let's talk about some of the physical treatments. Here's an overview of things. We'll go into the evidence in a few minutes, but there's growing evidence that improvements in physical fitness are directly correlated to physical pain relief, as we've just talked about. So the things that we're familiar with, such as directed movement-based therapies, such as physical and occupational therapy, are good for chronic pain, but even the other physical therapies that we don't know as much about, such as massage and acupuncture, have also been found to be beneficial in the treatment of chronic pain. So let's take a look at those things. By the way, I hope you all can hear me, and I hope I'm not going too fast. Just know that the slide set is certainly available for review in the future. Let's talk about hot tubs. Most people like hot tubs, and the 2008 Cochrane Review actually showed that the use of mineral baths or hot tubs showed actually some evidence in the big scheme of things on the evidence of benefit on the pain, quality of life, and decreased analgesic use in osteoarthritis. There's a section here that says bronze, silver, gold, and platinum. I just wanted you to know kind of what the level of evidence is. Bronze, of course, is the lowest level of evidence. Silver is not too bad. Gold and platinum, of course, are the best level of evidence. Higher levels of evidence include better RCTs and things like that. This particular review took a look at the silver level. They're still looking at RCTs, but they could have been a little bit more, could have been a little bit better, I guess you can say. Here's the use of heat or cold in 2011 on pain in terms of the knee. Ice massage has another silver level of evidence, beneficial in the range of motion, function, and strength of the knee. What I didn't put on the slide, and is I think also interesting, is that ice by itself not as useful. The level of evidence not so good, but if you massage with the ice, it's actually much better. And the massage with the ice generally takes place with a physical therapist. And a very interesting small study that I thought I'd throw in is about intranasal evaporative cooling for the treatment of migraine headaches. It's a very small study, but 13 patients, 11 of those patients had benefit from the intranasal evaporative cooling, and their headaches decreased significantly at 2 hours and longer term at 24 hours. Just showing us that maybe there is some other method of treating something like chronic headaches rather than just the use of abortifacin and sword narcotics. So anyway, let's talk about ultrasound a little bit. In 2010, there was a Cochrane review on the therapeutic benefits of ultrasound for knee and OA pain, and they found it was beneficial and there was no significant adverse event, which I think is quite significant when we're thinking about the use of medications, which all unfortunately have side effects, one or the other. I also threw in a little bit of information here about the things that these treatments are not actually necessarily good for. So for instance, in this case, therapeutic ultrasound, not so good for chronic low back pain on this 2014 Cochrane review. There's several problems with the review, low quality randomized trials. So I would like you to know that it's not necessarily that these therapies, such as ultrasound, therapeutic ultrasound, is beneficial for everything. It's beneficial for some things, just like every medication that we have, right? Okay. Osteoarthritis of the knees and hips, big factor. Many of our patients complain about these things. 2015 Cochrane review just came out. Exercise as effective as NSAIDs for knee pain due to OA. Wow. And has persistent benefits as far out as 6 months from the cessation of therapeutic exercise. That's pretty great. Land-based exercise in 2014 Cochrane review also found effective for osteoarthritis of the hip. Benefits lasted 3 to 6 months after cessation of therapeutic exercise. Land-based exercise seems to be a little bit better than water-based exercise, but still both are quite useful. Unfortunately, water-based exercise, such as exercise in the pool, not as long-lasting effects, but luckily for us, still beneficial. And truthfully, most importantly, the side effects from all these exercise studies showed that the side effects were minor and well tolerated by the majority of the patients. If we contrast that to the side effects or the risk of side effects from the commonly used medications, such as NSAIDs for osteoarthritis pain, that's pretty good in terms of the side effect profile for exercise. There's Tai Chi, there's yoga and massage. I see that I left out the information on massage, but there's also some good data on the benefits of massage for at least short-term benefits for low back pain. So Tai Chi has been found beneficial in arthritis, low back pain, range of motion, fibromyalgia, maybe even headaches and rheumatoid arthritis. Yoga, there's a meta-analysis and systematic review that found good benefit in short and long-term improvement in back pain and disability. And now there's a Cochrane review in the works. It's not quite out yet, but it's on the yoga treatment for chronic and non-specific low back pain, which is probably one of the broadest and most difficult categories to treat. Other exercise for low back pain. Cochrane review in 2011, exercise effective for decreasing pain and improving function in adults with chronic low back pain. And as you know, as all the guidelines now state, in acute low back pain, exercise trumps rest. So it doesn't really improve your pain better in acute sciatica, but it works well for acute low back pain. So the old standby of rest for a few days, now that we all know is now incorrect. Now we have some better evidence from the Cochrane review. Again, side effects from exercise, minor, well tolerated. Let's look at acupuncture. We've spent years wondering whether acupuncture is worthwhile or not, and I think at this point we finally have some very good evidence. There was a 2012 meta-analysis by Andrew Vickers, and actually he continues to publish several papers, but it showed actually a benefit of acupuncture versus sham acupuncture and versus no acupuncture, which is actually quite interesting because there's been some controversy about whether sham acupuncture is just as good. But if you take a look at the number of RCTs that he compiled or took a look at, that he reviewed, and the total number of patients, 17,000, almost 18,000 patients, it's a pretty good level of evidence that shows that acupuncture actually does have a benefit versus sham acupuncture and no acupuncture. In 2010, a Cochrane review showed a beneficial effect on pain management and labor with acupuncture and hypnosis actually, individually, not just acupuncture and hypnosis together. One more slide on acupuncture. In 2005, we had another review, Cochrane review, that found that acupuncture is beneficial for chronic low back pain and functional improvement and was still better than no treatment and sham treatment. Unfortunately, in this review, they found that most of the benefits were immediately after the treatment and the short term. In the Vickers review, Andrew Vickers found a little bit more benefit for the longer term. So at this point, I think that acupuncture has in some ways crested the level of evidence that is required to use it as a therapy. Of course, I might be a little bit biased, but on the other hand, I think we've gotten there. Chiropractic, on the other hand, is a little bit difficult to say. According to the 2011 Cochrane review, there's a small pain and disability benefit for combined chiropractic interventions on the treatment of acute and subacute low back pain. And when I say combined chiropractic interventions, it's the other things in addition to the manipulation. So maybe it's the use of the heat packs or the TENS unit or the other type of electrical stimulation. All those together have a little bit of benefit in acute and subacute low back pain. Unfortunately, it appears that the treatment of chronic low back pain with chiropractic may not be as useful. And this is actually from another Cochrane review. I just didn't put the citation there. So chiropractic, good for acute and maybe subacute low back pain, especially when combined with all the other treatments that are done in the chiropractic office. Well, that's just physical treatments. So let's talk about the psychological and behavioral treatments for pain, and then after that we'll talk about some of the miscellaneous treatments for pain, and then we'll be done. So some of the best evidence that we have for psychological and behavioral treatments deals with cognitive behavioral therapy, or otherwise known as CBT. So different types of cognitive behavioral therapy, such as comprehensive cognitive therapy and imagery and hypnosis-based CBT, actually found some good benefits on improving chronic pain in the short term. And actually, I would say the long term as well. Some of the more research coming out shows a little bit of a moderate to longer term benefit as well in decreasing pain, disability, altering mood, and decreasing the tendency to catastrophize outcomes. Pain education shows some promise, but truthfully, the research isn't there just yet. So just educating patients about why the pain is happening, where it's likely to go, how long it's going to last, things like that, maybe not quite as effective as more formalized cognitive behavioral therapy that's given by the therapist, or even they actually have internet methods of cognitive behavioral therapy at this point, internet methods of delivering it, which I think is quite neat. Okay, let's talk about something else, MBSR, which is mindfulness-based stress reduction, which is a technique that's eventually adopted from Eastern yogis, but comes to us out of Harvard and through the work of Jon Kabat-Zinn, just basically getting people to be a little bit more in the now rather than in the future or in the past, and helping them to stay in that place. And so my MBSR has been actually spreading across the country at this point. I think actually we teach it at the UNR as well, and it's shown to significantly decrease pain intensity and disability and increase pain acceptance, or in some ways the ability to take more pain or handle more pain when compared to weightless control. Has it beat pain education just yet? Maybe not just yet. And this is a study out of PLOS1. And relaxation techniques such as yoga are effective pain management techniques in labor as well, based on another Cochrane review. So pretty interesting information, I would say. Some other good information is on hypnosis. Multitude of favorable RCTs. We've got 2012, 2010 Cochrane reviews showing that hypnosis is beneficial, at least in labor pain, and some very good, strong evidence for the benefit of hypnosis in needle-related pain, procedure-related pain, I guess you could say, in children and adolescents in 2013 Cochrane review. So hypnosis actually appears to be quite useful, and if you remember a few slides back, hypnosis combined with cognitive behavioral therapy actually seems to be very useful as well. So maybe there's a benefit for hypnosis in the near future that we'll find out more. And finally, we talk about just some basic psychological treatments. And when we talk about these psychological treatments, we include relaxation techniques, coping strategies, other types of behavioral strategies. So not necessarily formalized cognitive behavioral therapy that's delivered by psychologists or psychiatrists, but slightly different therapies, I guess you can say. But even these therapies, even generalized psychological treatments, such as relaxation, coping strategies, and things like that, can be beneficial for headache pain and non-headache pain in children. And there seems to be some long-lasting benefit as well, especially if you give these psychological treatments in a face-to-face group as opposed to on the internet. In adults, very similar. So psychological therapy is delivered over the internet and actually in face-to-face as well, still effective for headache and non-headache pain in adults based on a Cochrane review. Another therapy called operant therapy, another type of psychological therapy, was also more effective than waiting lists for short-term pain relief. Quite interesting. So I think this points to the fact that many different types of behavioral therapies are good for at least short-term pain relief and maybe for long-term pain relief as well. And look at this. The last section of the slide says, as effective as group exercise. We've already gone over why exercise or how exercise is effective for chronic pain. And so now we see that behavioral treatment's also effective for chronic pain. That's pretty great. So it means that we can address chronic pain from both the physical as well as the psychological aspects, which is, as you remember, what we talked about in the beginning, due to the multifactorial nature of chronic pain. So we're almost done here. Let's talk a little bit about some of the miscellaneous treatments. So we talked about music, biofeedback, and cannabinoids. And I realize that many of us cannot prescribe cannabinoids, but I thought it was important just to put a slide on there. So let's talk about music first. There's a review that's currently being updated by a new author team, but it's a 2010 Cochrane review on the topic of music for pain relief, and whether or not listening to music helps with pain intensity and opioid requirements. And they found that there was actually a benefit to listening to music that you actually liked, not music that somebody else likes, in decreasing your short-term level of pain and your short-term need for opioids. It's a small benefit, but on the other hand, it is still a benefit, which means there's certainly a leeway to look at more research on the benefits of music, which I think is quite interesting. So let's talk a little bit about biofeedback as well. There's a specific type of biofeedback called heart rate variability coherence biofeedback, which is abbreviated HRVCB. Basically, it's the use of biofeedback to try to decrease, to try to in some ways standardize patients' heartbeats to make them less erratic. And they found in this very small pilot study with 14 veterans that if you can get these veterans to concentrate on stabilizing their heart rate, keeping it from jumping up and down, that this would actually be beneficial in decreasing pain. Small study, further studies are planned, but biofeedback may be a viable option as well. Finally, let's talk a little bit about cannabis. So there's now excellent RCT evidence that cannabinoids, of course in marijuana, have an effect size that's similar to all existing pharmaceutical pain medications in the short-term treatment of chronic pain. Of course, there are side effects: nausea, fatigue, dizziness, dry mouth, and the disturbances in cognition. These are pretty well tolerated in the study that was done by Lynch, the study of several different RCTs. I only mention cannabinoids because in some ways, despite the fact that they are somewhat pharmaceutical, and there are certainly versions that are pharmaceutical that you can buy at the pharmacy, this may be an ongoing or kind of a future direction that we should take a look at benefit for chronic pain. All right, I think we have 2 or 3 more slides. Let's talk about how we do it. Pain management in clinical practice. Because all our clinics are a little bit different, let's talk about just the general ideas that we should have. Of course, a comprehensive physical and a comprehensive history as well. But I think that we have enough evidence at this point that we should talk to our patients about lifestyle change in general, and then after that go into the multimodal interventions. And so unfortunately, the treatment of chronic pain, and you've probably seen this in your practice, is frustrating because you give them pain medication and unfortunately they come back and say, "Doc, my pain is not decreased," or "I need more." And so rather than give them more pain medications at that point, it may be useful to send them to a psychologist to take care of their emotional health, their psychological health, maybe send them over to the physical therapist, and of course continue to speak with them about lifestyle change, losing weight, exercising, getting rid of their cigarettes, things like that. And of course I'm not saying use the pharmaceuticals, never. Use the pharmaceuticals as indicated because it's an integrative pain management pattern or integrative pain management treatment, of which pharmaceuticals are just one aspect. Today we concentrated mainly on talking about the non-pharmaceutical methods, but please continue to consider your pharmaceuticals as an adjunct in addition to lifestyle change, helping people with their other modalities such as physical therapy or massage, acupuncture, chiropractic, biofeedback, many of the things that we talked about today. All right, and then finally, let's put this in perspective altogether. Here's the summary. Pain is a trifactorial, meaning physical, mental, and emotional factors cause pain or lead to pain, individualized phenomenon, which means that everybody has a slightly different experience of pain, and the thing that causes pain to one person is different than the thing that causes pain to somebody else. It's caused and modulated by many different things: physical, mental, and emotional status, emotional states, which means that pain has multiple causes, just in general, and is modulated by a lot of different factors, such as how things are going right now for you mentally, physically, and emotionally. And because of that, because it's so broad, because there's so many contributors to pain, the most appropriate management of pain, of all types of pain, whether we're talking about acute, subacute, or chronic, or we're talking about nociceptive pain or neuropathic pain, the best management of all these different types of pain, we could chunk it together and say, use a variety of therapies that address each one of the above factors, the physical, mental, and emotional states. As we know, unfortunately, our narcotic medications and our over-the-counter NSAIDs don't really address much more than the physical state. And so for the treatment, for the best treatment of pain, please consider the use of other emotional and mental factors as well. And then at this point, the last thing that's important to know is that in the past, we didn't have good evidence for non-pharmacological therapies, many of which we've talked about today. But at this point, we actually have some very good data. We have some good Cochrane reviews. Of course, they could be better, but on the other hand, the evidence is there at this point, especially for things such as acupuncture and, unfortunately, we didn't talk about herbal therapies. There's some in there as well. But cognitive behavioral therapies, lifestyle changes, so many different things that can be used for pain management, which is now evidence-based. So please feel free to broaden your use of these different factors in the treatment of pain. I think that's about it. Here's my leaf with the acupuncture needles, if you have any questions. I see somebody's typing, so let me just review just quickly. There's about 6 or 7 pages of references here. They're unfortunately not alphabetically organized, but on the other hand, there's a lot of different references. Most of these are references to Cochrane databases of systematic reviews, so just FYI. Okay, and so we'll go back to this question slide and see if we have any other questions. And hopefully we've ended a little bit early so that you can find some time to get lunch before you have to see patients again. All right. Well, I'll sit here and I'll wait for some questions, and if not, I think that we've got a wrap-up from either Jeannie or Jordan, and we'll see how things go. Thanks again for attending this webinar, and I realized that we went through quite a bit of different studies, and I feel like we may have glossed over some, but I feel like the most important thing was to give everybody a pretty good review of what's out there currently, and hopefully I've done some of the research for you and put it all in the references section so you don't have to look them up and struggle with the literature finding the information. And all the information is in the Cochrane review, so if you're looking for something specific, please start there. Okay, well, looks like no other questions.
Thank you so much, Dr. Chin. We so appreciated your time today. Incredible presentation. I wanted to direct you, if any of you did have questions, feel free to email us and we can get in contact with him to answer your questions. We have, this last slide here has links to our evaluation for CME credit. So you can browse to the SurveyMonkey and complete the evaluation, and it'll just auto-populate your CME certificate. And so please feel free to do that. We're going to leave this page open for about 10 minutes or until 1 o'clock, so you can browse through. You can download his file. So we have the notes from his presentation today. So if that was something you wanted to look at, feel free to download that and look at it for you. I also wanted to direct you to the webinars that we have in the series. We have 2 in June. If you had any interest in seeing any more of our webinars, please go to our website, which I'll put in the chat in just a second. We also have several other programs that you see on the website that may be interesting to you. We have an opioids program on June 25th. That one's in Las Vegas. So for any of our Las Vegas doctors, please register for that and program. The Nevada Cancer Control Summit is on September 17th and 18th. And our Nevada Public Health Association Annual Conference is on September 24th and 25th. So I'm going to throw our website after we can go and see the programs that sound interesting to you. That. And let me know if you have any questions. I'll be around on the phone and available by email if anything doesn't work or you need help with anything. So again, thanks for joining us today, and thank you to Dr. Chin.